There is something I need to tell you before we go any further. I have been a doctor for a long time. I have sat across from thousands of patients. I have read more clinical trial data than I can count. And there are moments in medicine, rare moments, where the research says something so clearly, so consistently, so undeniably, that staying silent becomes its own kind of harm. This is one of those moments. What I am about to share with you involves three of the most commonly prescribed blood pressure medications in the world, pills that are sitting in medicine cabinets across this country right now, pills that millions of seniors swallow every single morning, trusting that they are doing what they were prescribed to do. The research says otherwise, not fringe research, not alternative medicine, the largest blood pressure trials ever conducted, published in the most respected journals in cardiovascular medicine, presented at the most prestigious cardiology conferences in the world. Research that changed the guidelines eventually after a delay of years and in some cases decades that cost people dearly. These three pills are quietly doing the opposite of what your doctor told you they would do, and the damage they cause looks exactly like aging. It feels exactly like getting old. And it has been blamed on everything, your diet, your stress, your genes, your age, except the pill that is actually causing it. I am Dr. Amelia Carter. I work at the intersection of functional medicine and vascular biomechanics. I study what medications actually do inside the aging cardiovascular system, not just what they do to the number on a blood pressure cuff. And today, for the next 50 minutes, I am going to give you the most important cardiovascular education of your life. But before I say another word, I need to say this clearly, and I mean every word of it. Do not stop, reduce, or change any medication you are currently taking without talking to the physician who prescribed it. Some of these medications, particularly the first one we will discuss, are genuinely dangerous to stop suddenly. We are talking about a supervised conversation with your doctor, not a unilateral decision made after watching a video. What I am giving you today is knowledge. The kind of knowledge that walks you into your doctor's office prepared, informed, and able to ask the right questions. The kind of knowledge that turns a 5-minute appointment into a real conversation. Use this video as preparation, not as a prescription. Now, let me tell you about Lester. Lester was 73 years old, a retired postal carrier from Dayton, Ohio. For 31 years, Lester walked 12 miles a day delivering mail in every kind of weather: summer heat, winter ice, spring rain. The most reliable man on his route. His neighbors set their clocks by him. When he retired, walking was simply part of who he was. 3 miles before breakfast, rain or shine, every single morning. Then his doctor put him on a blood pressure pill. Within a year, the morning walk stopped. Lester told his wife he just did not feel like going out anymore. He sat in his recliner most of the day. His wife thought he was depressed. His daughter thought he was giving up. His doctor said he was managing fine because his blood pressure at the 1 o'clock appointment looked perfect. Lester was not depressed. Lester was not giving up. Lester was on a medication that had chemically removed the one thing that made him get out of the chair every morning. And the evidence that this medication was doing this, the evidence that it was inferior to the alternative, had been sitting in the medical literature for over 20 years. We are going to come back to Lester throughout this video because his story is not unique. His story is happening right now in living rooms and recliners across this country, and by the time we are done today, you are going to understand exactly what happened to him, why it happened, and most importantly, what changed when someone finally asked the right question. There are 3 types of people watching this video right now. The first type takes their blood pressure pills every single morning without ever questioning whether those specific pills are still the right ones for their body at their age with their kidneys and their metabolism. The number on the cuff looks good. The doctor says everything is fine, and so they trust it. The second type, and I believe this is most of you, has felt something: the fatigue that sleep does not fix, the blood sugar that keeps creeping up even though the diet has changed, the swollen ankles the doctor keeps calling fluid retention, the palpitations that come out of nowhere while sitting quietly on the couch, the morning heaviness that never fully lifts. You have noticed, you have wondered, you have suspected that the pill might be connected to how you feel, but you did not know how to prove it, and you did not know what to say to your doctor without feeling dismissed. The third type asked for the right blood tests, brought the study names to the appointment, had the informed conversation, and either switched to a modern alternative or had a genuine reassessment of whether their current medication was still the right choice for their body today. This video is about how you become the third type. Let me set the foundation before we get to the 3 medications. Because to understand why these pills are causing problems, you need to understand something that most doctors do not have time to explain in a routine appointment. The number on your blood pressure cuff is not the number that determines whether you have a stroke. Read that again. Because it is the single most important sentence in this entire video. Your blood pressure cuff measures the pressure in the large artery in your upper arm. It is a convenient, accessible, reliable measurement, but it is a peripheral measurement. It is not measuring the pressure inside the aorta, the main pipe that leaves your heart and feeds your brain. And here is why that distinction matters enormously. When your heart contracts and pumps blood out, it sends a pressure wave down the aorta like a shock wave traveling through a tunnel. That wave travels all the way down to where the arterial system branches, roughly at the level of your pelvis, and a portion of it bounces back, like an echo. That reflected wave travels back up toward the heart. In a young, healthy cardiovascular system, the aorta is elastic and flexible. The wave travels quickly, reflects, and returns. Crucially, it returns after the heart has finished its contraction, during the relaxation phase. During that relaxation phase, the reflected wave arriving back at the aortic root actually helps push blood into the coronary arteries that feed the heart muscle itself. It is a beautifully timed system. As we age, the aorta stiffens. The wave travels faster through stiffer tissue. The reflected wave returns earlier, and in older adults, particularly those on certain medications that alter heart rate and vessel tone, the reflected wave can arrive while the heart is still actively contracting. 2 forces colliding head-on inside the main pipe that feeds your brain and your heart. Your arm cuff cannot detect this collision. It cannot distinguish between a perfect pressure wave arriving at the right time and a chaotic collision of forward and reflected waves happening inside your chest. Your doctor sees a 128/82 on the cuff and says, "Perfect." The number on the chart has been managed. What is happening inside your aorta may be an entirely different story. This is the foundation. Hold it in your mind as we go through each of the 3 medications, because this is the mechanism through which outdated medications can simultaneously lower the arm cuff number while increasing the damage inside the vessels that matter most. The first medication is Atenolol. You may know it by its brand name, Tenormin. It is a small white or pink tablet. It has been prescribed since 1976, and it is still one of the most commonly written blood pressure prescriptions in the United States today. I want to tell you something that cardiologists say to each other at conferences that they do not always say to their patients. Among cardiologists, Atenolol has been privately referred to as the placebo with side effects. That phrase was born from a devastating piece of research. In 2004, Dr. Bo Karlberg at Umeå University in Sweden published an analysis that shook the cardiology community. His team reviewed every major Atenolol trial ever conducted, data from over 24,000 patients. They were not looking at what happened to the number on the blood pressure cuff. They were looking at what happened to the people who had heart attacks, who had strokes, who lived, who did not. When Atenolol was compared head-to-head against a placebo, a sugar pill, it reduced cardiovascular mortality by exactly 0%. Not a small reduction, not a modest benefit. 0. It did not prevent a single heart attack. It did not extend a single life compared to doing nothing. The only things it reliably produced were a lower number on the blood pressure cuff, chronic fatigue, a blunted heart rate, rising blood sugar, and problems in the bedroom that nobody discussed at the appointment. It was still being prescribed to millions of people. Now let me explain why Atenolol fails so spectacularly at its stated job, despite reliably lowering the arm cuff number. This brings us back to the physics we just discussed. Atenolol is a beta-1 selective blocker. Its primary mechanism is to slow the heart rate. When the heart beats more slowly, the pressure wave it generates takes longer to complete its journey. And here is the consequence that the original researchers in 1976 did not fully understand. When the heart slows down, the timing of the reflected wave changes. Remember the echo coming back up the aorta? In a slower heart, the heart is still in the middle of its contraction phase when that reflected wave arrives. Instead of arriving during the relaxation phase, where it should arrive, it crashes back into the aorta while the heart is still pushing blood out. Forward wave meets reflected wave head-on. Central aortic pressure spikes. The arm cuff sees the average. It does not see the collision. This was precisely what was measured in the CAFE study, the Conduit Artery Function Evaluation Sub-Study, which was embedded within the massive ASCOT trial. This study measured both arm pressure and central aortic pressure in the same patients simultaneously. The arm pressure between the Atenolol group and the comparison group was nearly identical, just 0.7 millimeters of mercury apart. Essentially the same, but the central aortic pressure, the pressure inside the pipe actually feeding the brain, was 4.3 millimeters of mercury higher in the Atenolol group, despite the arm numbers looking the same. 4.3 points does not sound dramatic, but when that pressure differential is applied to the delicate capillary networks inside the brain, sustained every single heartbeat, every single day, year after year, the cumulative damage to the microvascular architecture of the brain is significant. The LIFE trial confirmed the consequences. Over 9,000 seniors were randomized to receive either atenolol or losartan, an ARB, a completely different class of medication. The researchers carefully matched the two groups so that arm blood pressure readings were nearly identical throughout the trial. The results were unambiguous. The losartan group had 25% fewer strokes than the atenolol group, despite the same arm numbers. The losartan group developed 25% less new-onset diabetes than the atenolol group. Same arm numbers, dramatically different outcomes, because the arm number was never the number that mattered. This trial was published in 2002, the evidence was clear, and atenolol continued to be prescribed to tens of millions of people for years and continues to be written on prescriptions today. Now, I want to explain what atenolol does to the body beyond blood pressure, because the fatigue, the blood sugar, the bedroom problems, these are not coincidences. They are direct, predictable, mechanistic consequences of what this drug does at the cellular level. The fatigue first. Atenolol places a chemical ceiling on your heart rate during physical exertion. Regardless of what your muscles demand, regardless of how hard you are working, your heart rate under atenolol cannot adequately rise above roughly 110 to 120 beats per minute. A healthy senior during a brisk walk should have a heart rate of 130 to 150 beats per minute, delivering oxygenated blood to working muscles at the rate those muscles require. Under atenolol, the heart is held back. Your muscles send distress signals. They are working hard and not receiving adequate oxygen. Your perceived exertion skyrockets. A walk that should feel manageable feels exhausting. A flight of stairs that should be routine leaves you winded. You feel this as fatigue. You feel it as weakness. You feel it as being out of shape. You interpret it as getting old. And here is the cruelest part of this mechanism. When exercise feels impossible, you stop exercising. When you stop exercising, your muscle mass declines. Your cardiovascular fitness deteriorates, your balance worsens, your bone density decreases, your fall risk increases, your actual cardiovascular disease risk, the thing the medication was prescribed to reduce, goes up. Because physical inactivity is one of the 5 most powerful risk factors for cardiovascular disease. Atenolol forces inactivity by making exertion feel unbearable. And inactivity creates the very cardiovascular risk the drug was prescribed to prevent. It is a spiral, and it happens one missed walk at a time. The seniors trial, a large clinical study specifically in older adults, confirmed that this fatigue on atenolol is not simply from lower blood pressure. It is from reduced cardiac output and skeletal muscle oxygen starvation. Crucially, the researchers compared atenolol to newer beta blockers like nebivolol and found that nebivolol does not cause this fatigue because nebivolol simultaneously releases nitric oxide, maintaining blood flow to peripheral muscles. The fatigue is not an unavoidable consequence of controlling blood pressure. It is a specific defect of an outdated drug. 26% of seniors on Atenolol report fatigue severe enough to limit daily activity. 1 in 4. Now the blood sugar. Your pancreas contains clusters of cells called beta cells. Their job is to manufacture insulin and release it into the bloodstream in response to rising blood glucose. The release mechanism works like this. Glucose enters the beta cell, triggers a series of metabolic reactions, and ultimately causes calcium channels to open. When calcium floods into the cell, it activates a fusion process. Tiny packets of insulin fuse with the cell wall and release their contents into the blood. Atenolol blocks the beta-2 adrenergic receptors on the surface of pancreatic beta cells. When these receptors are blocked, the calcium signaling cascade cannot be properly initiated. The calcium channels do not open adequately. The fusion mechanism stalls. The insulin has been manufactured. It is sitting inside the beta cell in ready packets, but the delivery mechanism has been chemically frozen. Meanwhile, glucose from your meals arrives in the bloodstream with nowhere to go. Blood sugar rises. Your doctor checks your fasting glucose and sees a number that is climbing, 105, then 112, then 118. Your doctor says you are pre-diabetic. He tells you to watch your carbohydrates. You cut out bread, you cut out pasta, you eliminate sweets, you avoid fruit. Your fasting glucose barely moves because the problem was never your diet. The problem is a pill that has frozen the insulin delivery system inside your pancreatic cells. The ERIC study, the atherosclerosis risk in communities study, confirmed a 28% increased risk of new-onset type 2 diabetes in patients on Atenolol, not from poor dietary choices, from a blood pressure medication paralyzing the cells responsible for releasing insulin. If you are on Atenolol and your blood sugar has been creeping upward while your diet has been getting stricter, your pancreas is not failing. It is being held hostage. And there is one more mechanism of Atenolol I need you to understand, because it connects to something that affects quality of life profoundly, but almost never gets discussed in a routine appointment. Atenolol is beta-selective. It primarily blocks beta-1 receptors in the heart, but it leaves alpha-1 adrenergic receptors throughout the body completely unopposed. Alpha-1 receptors are vascular gatekeepers. Their job is to constrict blood vessels. Under normal circumstances, beta receptors provide a counterbalancing dilating influence. Remove that counterbalance and the alpha-1 receptors clamp down on blood vessels throughout the body, including the blood vessels that supply circulation to the pelvic region. The Medical Research Council trial documented a 12.6% incidence of sexual dysfunction in men on Atenolol. The arousal signal fires. The nerves release nitric oxide, but the alpha-1 receptors have constricted the arteries shut. The signal reaches a locked gate. This does not get discussed at appointments. Men assume it is age. Women assume it is age. It is not age. It is a vascular mechanism caused by a drug that was approved in 1976. Lester was on Atenolol. His heart rate was stuck at 52 beats per minute. His fasting glucose had risen from 95 to 118 over 2 years, and he had eliminated bread, pasta, sweets, and fruit, trying to bring it down. He could not walk to the mailbox without feeling winded. His ankles were swollen. His doctor saw 128 over 82 at the 1 o'clock appointment and said everything looks great. We will come back to what happened when Lester's daughter, a nurse practitioner, finally looked at his prescription bottles and asked one question that changed everything. But first, we need to talk about the second pill. The second medication is hydrochlorothiazide. Your doctor may call it HCTZ. It has been prescribed since 1959. It is one of the most widely used blood pressure medications on Earth. Your doctor chose it because it is inexpensive, familiar, and it reliably lowers the number on the blood pressure cuff. What your doctor may not have explained is what it drains from your body along with the water, and what that drainage does to your heart's electrical system, your arteries, and your skin. Let me explain the mechanism clearly. HCTZ is a thiazide diuretic. It works inside the kidney at a structure called the distal convoluted tubule, the section of the kidney's filtration system responsible for fine-tuning what gets kept and what gets excreted. HCTZ blocks a specific transporter in this tubule, the sodium chloride cotransporter, preventing the reabsorption of sodium. The sodium stays in the urine. Water follows the sodium out. Blood volume decreases. Pressure drops. Simple and effective for its intended purpose. But what happens downstream is where the problems begin. The sodium that HCTZ forces out of the distal tubule does not simply leave the body quietly. It moves downstream into the collecting duct, the final section of the kidney's tubular system. The collecting duct encounters this wave of sodium and responds by activating a hormone called aldosterone. Aldosterone tells the collecting duct to reabsorb the sodium, but to do so, it must exchange something. It exchanges potassium. Your body dumps potassium into the urine to recover the sodium, day after day. Month after month, year after year, your serum potassium begins falling from a healthy 4.2 down to 3.9, down to 3.6, down to 3.4. At 3.4, your doctor looks at the lab result and says, borderline low, maybe eat a banana. Here is what 3.4 actually means inside your heart. Every heartbeat follows a precise electrical sequence. Sodium ions rush into the cardiac muscle cells to trigger contraction. Then, to reset the electrical charge so the heart can beat again, potassium channels must open and allow potassium to flow back out. This repolarization, this electrical reset, is entirely dependent on adequate potassium. When potassium is low, the repolarization drags. The heart is caught in an electrical twilight, neither fully contracted nor fully ready to beat again. On an electrocardiogram, this appears as a prolonged QT interval, the electrical signature of a heart that cannot reset itself properly. And in this prolonged, vulnerable window, a rogue electrical impulse originating from elsewhere in the heart can trigger a chaotic rhythm called torsades de pointe. The heart quivers instead of pumping. Blood stops reaching the brain. You lose consciousness. Or worse. Your doctor looked at 3.4 and suggested a banana. An electrophysiologist would have called it a ticking clock. At 25 milligrams of HCTZ, the standard starting dose, between 10 and 20% of seniors develop clinically significant hypokalemia. At 50 milligrams, up to 40%. But potassium is not the only mineral being stripped. HCTZ depletes magnesium through the same mechanism, and the consequences inside your arteries are something most people have never heard of and cannot feel until the damage is already done. Inside the walls of your arteries are smooth muscle cells. These cells are responsible for the artery's flexibility, its ability to dilate and contract in response to the body's needs. Magnesium is essential to these cells' identity as smooth muscle cells. When intracellular magnesium falls below a critical threshold, these cells undergo a profound and irreversible transformation. They activate a genetic transcription factor called RUNX2. RUNX2 is not a vascular gene. It is the master switch for bone formation. It is the signal that tells stem cells to become bone-building cells. When smooth muscle cells in the artery wall activate RUNX2, they forget they are supposed to be flexible vascular tissue. They begin behaving like bone builders. They start secreting calcium and phosphate directly into the arterial wall matrix. Your artery is literally calcifying from the inside out. This is not metaphor. This is a mechanistic, histologically confirmed process. The artery wall deposits calcium. It stiffens. It loses its ability to dilate. Blood pressure rises further. The physician sees rising blood pressure and increases the dose of HCTZ, which strips more magnesium, which drives more RUNX2 activation, which calcifies the artery further. No blood pressure medication can reverse arterial calcification. No drug can uncalcify bone inside a living artery. The damage, once done, is structural and permanent. And now I need to tell you about your skin. The HCTZ molecule contains a structural component called a sulfonamide ring. This ring acts as a photosensitizer, a chemical that, when embedded in skin cells, becomes violently reactive to ultraviolet light. When you go outside and sunlight reaches your skin, the UV photons from the sun strike the HCTZ molecules sitting inside your skin cells. The molecules absorb this energy, they become electronically excited, and they shed electrons, generating swarms of free radicals that tear through the DNA inside your skin cells with enormous destructive force. In a healthy person exposed to normal sunlight, DNA repair enzymes handle the occasional mutation. The system copes. But the volume of drug-amplified damage that HCTZ creates overwhelms those repair mechanisms. Mutations pile up faster than they can be corrected. Cells lose the ability to regulate their own division. They become cancerous. A study using the Danish Cancer Registry, one of the most comprehensive cancer databases in the world, found a 700% increased risk of squamous cell carcinoma after a cumulative dose of approximately 50,000 milligrams of HCTZ. At 12.5 milligrams per day, the lowest commonly prescribed dose, that cumulative threshold is reached in approximately 11 years. At 25 milligrams per day, in about 5.5 years. If you have been on HCTZ for 5 years or more, your skin deserves careful attention tonight. Check for any lesions that are rough to the touch, that bleed when scratched, that have not healed after several weeks. Squamous cell carcinoma is highly treatable when caught early. It is the delay, the years of assuming a skin change is nothing, that allows it to progress. And now, if what I have described about HCTZ and Atenolol has concerned you, I need you to brace yourself slightly for what comes next. Because the third medication is the most widely prescribed blood pressure drug in the world. It is in more medicine cabinets than any other cardiovascular medication, and its most dangerous effect is one that almost no one discusses. The third medication is Amlodipine, brand name Norvasc. Amlodipine is a calcium channel blocker. Its mechanism of action is straightforward and genuinely effective. It blocks the L-type calcium channels in the smooth muscle cells of your artery walls. Without calcium entering these cells, they cannot contract. The artery wall relaxes, the artery opens, blood flows more easily, pressure drops. This is real. It works. Amlodipine is very effective at lowering the number on the blood pressure cuff. But here is what the simplified explanation leaves out. And leaving it out has consequences that accumulate over years and decades inside the aging cardiovascular system. The L-type calcium channels that amlodipine blocks are found specifically in the precapillary arterioles, the tiny arteries that feed blood into the capillary beds of the body's tissues. Under the influence of amlodipine, these arterioles dilate aggressively. They open wide. But the vessels on the other side of the capillary bed, the post-capillary venules that drain the capillary beds, do not have L-type calcium channels. The drug cannot affect them. They remain at their resting tone. What you now have is a system where a fire hose volume of blood is being forced into a capillary bed that can only drain through a narrow exit. The hydrostatic pressure inside those capillaries rises dramatically. And capillary walls, which are semi-permeable by design, designed to allow small amounts of fluid and nutrients to seep through into surrounding tissue, cannot withstand this drug-induced pressure. Plasma fluid is pushed through the capillary walls in large quantities and deposited into the tissue of the ankles and lower legs. Dependent edema, swollen ankles. At 5 milligrams of amlodipine, the starting dose, between 3 and 11% of patients develop this ankle edema. At 10 milligrams, a commonly prescribed higher dose, up to 30%. In women, the rates are consistently higher. Your doctor sees swollen ankles. Your doctor prescribes a diuretic to remove the fluid. Now you are on 2 medications. The diuretic strips potassium and magnesium. You begin accumulating the HCTZ side effects alongside the amlodipine side effects. The diuretic does not fix the pressure mismatch inside the capillaries. Amlodipine continues forcing fluid out. The swelling returns. The doctor considers increasing the diuretic dose. A medication to treat the side effect of a medication becomes its own disease. This is what is called a prescribing cascade. A pill creates a problem. A second pill is prescribed for the problem. The second pill creates another problem. A third pill is added, and the patient, who came to the doctor because of high blood pressure, is now managing 3 medications, each treating a side effect of the others, while their kidneys, their heart, and their mineral balance are being affected by all 3 simultaneously. But the most dangerous thing amlodipine does is not the swollen ankles. It is what happens inside your cardiovascular control system when the drug forces your blood pressure down. When amlodipine opens your arteries and drops your blood pressure, baroreceptors, pressure sensors located in the walls of the large arteries in your neck, detect the falling pressure. They interpret this drop as a medical emergency. In the baroreceptor's evolutionary logic, a sudden drop in arterial pressure means one thing: you are losing blood. The brain receives the alarm signal and activates the sympathetic nervous system. The kidneys receive a panic signal and engage the renin-angiotensin-aldosterone system, the RAS. The RAS is the body's primary fluid retention emergency response. The kidneys begin retaining sodium and water aggressively, expanding blood volume to compensate for the perceived blood loss. But there is no blood loss. The blood pressure dropped because of a drug. The body does not know this. It responds to physiology, not pharmacology. Now your heart must pump an artificially expanded volume of fluid with every contraction. The kidneys, convinced that blood loss is ongoing, continue signaling for fluid retention, month after month, year after year. Your heart is working against an artificially expanded ocean of fluid every minute of every day. The left ventricle, the main pumping chamber of your heart, responds to this chronic pressure overload the way any muscle responds to overwork. It enlarges. The walls stretch under the sustained strain. The thick, powerful muscle that a healthy heart requires begins to thin and weaken. The pumping efficiency drops. The heart that was beating against high blood pressure begins to fail from a different direction, not from pressure, but from volume overload and structural remodeling caused by the drug that was supposed to protect it. The All-HAT trial, one of the largest antihypertensive treatment trials ever conducted, involving over 33,000 patients, found a 38% higher risk of heart failure in patients on amlodipine compared to the alternative treatment studied. A pill prescribed to protect the heart, increasing heart failure risk by 38%, because of a reflex nobody warned you about. Now I need to bring all 3 of these medications together, because many seniors are not on one of them, they are on all 3, simultaneously: Atenolol, Hydrochlorothiazide, Amlodipine. And when these 3 drugs share a body, particularly an aging body with kidneys and a liver that process medications more slowly than they once did, the interactions between them create a combined effect that is significantly more destructive than any one of them alone. Let me explain why aging changes the equation so fundamentally. Atenolol is eliminated almost entirely by the kidneys. At 45 years old, your kidneys filter blood at full capacity, an estimated glomerular filtration rate above 90. At 75, natural aging alone typically reduces that eGFR to somewhere between 45 and 65. Your kidneys are filtering at roughly half their previous speed. When you take your daily 50 mg Atenolol tablet, aging kidneys cannot clear it from your system before the next morning's dose arrives. The drug accumulates. What the prescription bottle calls a 50 mg dose is behaving more like a 90 or 100 mg dose in the body of a 75-year-old. Your heart rate can drop into the dangerous low 40s, not because of worsening disease, because of an accumulation of a drug your body can no longer process at the speed the dosing schedule was designed for. Amlodipine is processed by the liver through an enzyme system called CYP3A4. By age 70, blood flow to the liver has decreased by 30 to 40%, and the liver has physically reduced in size. Amlodipine already has an extraordinarily long half-life, 30 to 50 hours even in a younger person. In a senior with reduced liver function, that half-life extends dramatically. The drug accumulates between doses, the ankle swelling gets worse, the RAS activation intensifies, not because the prescription changed, because the body's ability to process the drug changed and nobody adjusted the dose. HCTZ behaves differently still. As kidney function declines, HCTZ becomes progressively less effective at its primary job, lowering blood pressure. The kidney tubules that HCTZ targets are no longer functioning at full capacity, but HCTZ remains fully effective at draining potassium and magnesium. You receive all of the side effects and progressively less of the benefit. The risk-to-benefit ratio quietly inverts with each passing year of aging. Now place all three of these aging-altered pharmacokinetics into one body, interacting with each other simultaneously. Amlodipine triggers the RAS. The kidneys respond to the RAS activation by retaining sodium and water. Your blood volume expands, but HCTZ is simultaneously trying to force sodium and water out through the kidney tubules. Your kidneys are receiving two contradictory commands at the same time: retain everything, dump everything, from two drugs prescribed by the same doctor at the same appointment. This pharmacological tug-of-war does not resolve itself cleanly. The kidneys are caught between two opposing signals. The delicate filtering units, the nephrons, bear the mechanical and chemical stress of this conflict. Over time, kidney function deteriorates. And as kidney function deteriorates, Atenolol accumulates faster and the cycle deepens. Meanwhile, HCTZ is stripping potassium. The heart's electrical reset system is running on diminished fuel. If the heart begins to develop arrhythmia, if that rogue electrical impulse fires during the prolonged QT window, the sympathetic nervous system would normally release adrenaline to stabilize the rhythm, the body's own cardiac rescue mechanism. But Atenolol has blocked the beta-1 receptors that adrenaline would activate in the heart. The rescue signal fires. It bounces off a locked receptor. The emergency response cannot reach its target. HCTZ pushes the heart toward the electrical cliff. Atenolol removes the safety net. And simultaneously, HCTZ has depleted the potassium that pancreatic beta cells need to trigger insulin release. Atenolol has blocked the beta-2 receptor that completes the insulin release mechanism. The pancreatic cell is under a double chemical siege from two different drugs prescribed by the same doctor. Blood sugar climbs. The doctor sees prediabetes. The patient cuts carbohydrates. The blood sugar barely moves. Nobody connects it to the prescriptions. Lester was on all three. His fasting glucose was 118 and climbing despite dietary restriction. His potassium was 3.4. His heart rate was stuck at 52. His ankles were swollen. His morning walks were gone. His mornings were spent in a recliner, waiting to feel like himself again. His doctor's chart said 128/82 at the 1 o'clock appointment. Everything looks great. Lester's daughter is a nurse practitioner. She came for a Sunday dinner visit, and she did something nobody had done in years. She looked at his prescription bottles. She read the labels, and she asked one question. "Dad, why are you on Atenolol?" The life trial proved that losartan produces better outcomes 20 years ago. She called his prescribing physician the following week. She came prepared. She brought the life trial data. She brought the CAFE study results. She brought his fasting glucose trend over 2 years. She brought his potassium levels. She asked for a supervised transition. His physician agreed to a gradual taper of Atenolol, 4 weeks, reducing the dose in stages to prevent the rebound tachycardia that abrupt Atenolol cessation can cause, with simultaneous introduction of losartan, the ARB that the life trial had proven superior. Here is what happened. Week 1 of the taper. The chemical blockade on Lester's beta-1 receptors began to lift. His heart rate rose from 52 to 67 beats per minute. Oxygenated blood began reaching his leg muscles at the volume they needed. The crushing fatigue that had settled into his thighs and calves began to release. Week 2. The beta-2 receptors on his pancreatic cells were finally unblocked. The backlogged insulin that had been trapped inside those cells by the receptor blockade was released. His fasting glucose began dropping for the first time in 2 years without any change to his diet. Month 1. His fasting glucose dropped from 118 to 96. The pre-diabetes diagnosis that had been driving him to restrict his diet for over a year disappeared from his chart. The food he had been denying himself, fruit, whole grain bread, occasional pasta, was never the problem. Month 2. The alpha-1 vasoconstriction caused by the unopposed receptors began resolving. Blood flow to peripheral tissues improved. Month 3. Lester walked 3 miles before breakfast. Not because he found motivation, not because he decided to push through the fatigue, because the chemical restraint had been removed. His heart could deliver oxygen to his muscles the way it was designed to. The walks came back because the physiology came back. His daughter called to check on him. He was outside when she called. She could hear the wind in the background. He was on his 2nd mile. Lester was not getting old. Lester was getting medicated. Now let me give you something concrete and actionable, because information without a pathway forward is just anxiety. If you are on any of these 3 medications, here are the specific blood tests that reveal whether the damage we have discussed is occurring in your body. Take this list to your next appointment. Ask for these tests by name. If you are on HCTZ, ask for serum potassium and RBC magnesium. This distinction is important. Serum magnesium measures what is circulating in your blood, which can appear normal even when your cells are depleted. RBC magnesium, red blood cell magnesium, measures what is actually inside your cells, where the calcification preventing work happens. Ask specifically for RBC magnesium, not just serum magnesium. Also ask for a basic skin check. If you have been on HCTZ for 5 or more years, ask your primary care physician for a dermatology referral. The squamous cell carcinoma risk is dose and duration dependent, and early detection makes an enormous difference. If you are on Atenolol, ask for a fasting glucose and a fasting insulin level together. The combination is important. If your fasting glucose is elevated but your fasting insulin is low or low normal, that pattern is consistent with impaired insulin release, the beta-2 receptor blockade mechanism. The problem is not insulin resistance, it is insulin delivery failure. Your doctor may not recognize this pattern unless you bring it to their attention. Also ask for a resting heart rate check first thing in the morning before your pill. If your resting heart rate is below 55 consistently, especially in the context of fatigue, that is a clinically relevant data point. If you are on Amlodipine, ask for plasma renin activity and serum aldosterone. If both are elevated, your kidneys are in a state of sustained sympathetic activation. The RAS panic response we discussed. This is the mechanism driving fluid retention and long-term cardiac remodeling. Documenting this elevation gives your doctor objective evidence of the process occurring in your body. And now, here are the exact words to use with your doctor. Not to confront, not to demand. To open a real, evidence-based conversation between 2 people who share the same goal: your long-term health. If you are on Atenolol, say this: Doctor, I have been reading about the LIFE trial, which followed 9,000 patients and found that losartan reduced strokes by 25% more than atenolol and reduced new-onset diabetes by 25%, despite identical arm blood pressure readings. I have also been experiencing fatigue that limits my activity, and my fasting glucose has been rising despite dietary changes. I would like to discuss whether a supervised taper from Atenolol to an ARB might be appropriate for my situation. If you are on HCTZ, say this: Doctor, I have been reading about a 2018 study using the Danish Cancer Registry that found a 700% increased risk of squamous cell carcinoma after long-term HCTZ use. I have been on HCTZ for several years. I would like to discuss whether switching to indapamide, which the research suggests is metabolically neutral, or a potassium-sparing alternative might be appropriate, and I would like to have my RBC magnesium and serum potassium checked. If you are on Amlodipine, say this: Doctor, I have been reading about the ALL-HAT trial, which found a 38% higher risk of heart failure with Amlodipine compared to alternative treatments, and I understand this is related to RAS activation. My ankles have been swelling, and I am concerned about adding a diuretic to treat what may be a drug-induced mechanism. I would like to discuss whether an ARB might address both my blood pressure and reduce the RAS activation simultaneously. If your doctor responds that you are stable, and many will, I want you to understand what stable actually means in clinical language. Stable means the number on the chart has not gotten worse since the last measurement. It does not mean you feel well. It does not mean the mechanisms we discussed are not occurring. It does not mean the current prescription is optimized for your body at its current age with its current kidney function. Stable is a chart notation. It is not a guarantee of well-being. And do not, please hear me clearly, do not stop any of these medications on your own. Atenolol especially must be tapered under medical supervision. Stopping atenolol suddenly can cause rebound hypertension and a sharp, dangerous spike in heart rate that can trigger a cardiac event. The transition away from atenolol is safe when done gradually and supervised. It is potentially dangerous when done abruptly and alone. I want to close with something that I believe is one of the most important facts in all of cardiovascular medicine. Something that should make every person watching this feel not just informed, but genuinely hopeful. The average time between a landmark clinical study proving that a medication is inferior and that finding being incorporated into standard medical guidelines is 17 years. 17 years. The LIFE trial proving atenolol's inferiority was published in 2002. It took until 2014 for major guidelines to begin downgrading it. During those 12 years, tens of millions of new atenolol prescriptions were written. Your prescription does not have an expiration date. It renews automatically. The science moves forward. The prescription stays frozen. In Australia, Canada, and the Netherlands, a practice called systematic deprescribing has been formalized into clinical care. Physicians conduct an annual medication review for older adults, asking not just whether the drug is still needed, but whether this specific drug is still the right choice for this specific person at this specific age with this specific organ function. Research from these programs found that this annual reassessment reduced one-year mortality by 88% compared to routine care. 88%. Not from a new drug, not from a breakthrough treatment, from asking one question once a year. Is this still the right pill for me? Lester went from 3 pills to 1. Losartan. His blood pressure is 126/80. His fasting glucose is 96. His potassium is 4.1. His ankles are normal. His heart rate is 67 at rest and rises appropriately when he walks. His morning walk is 3 miles before breakfast. He is 74 years old. He walks faster than he did at 72. His doctor did not discover this. His daughter did. By reading a label, by asking a question, by bringing the evidence to the appointment instead of waiting for the appointment to bring the evidence to her. That is what today was about. That is what these 50 minutes were for. Your doctor has 5 minutes at an appointment and a prescription that was last reviewed when your kidneys were younger, your liver processed medication faster, and the science had not yet caught up to what we now know. This video just gave you what the science knows now. The question, the only question that matters as you walk out of this video today, is what you do with it at your next appointment. Take the blood tests, bring the study names, use the exact words. Ask whether this is still the right pill for you at your age with your body today. You are not asking your doctor to make you a promise. You are asking your doctor to have a real conversation, the kind of conversation that your health and the decades of life you still have ahead deserves. I am Dr. Amelia Carter. Thank you for spending this time with me today. Take care of your heart, take care of your body. I'll see you in the next video.